today my topic would be on beyond medicines, leveraging social determinants and the strengthened health system for a brighter future in breast cancer care. In line with the track today, I thought that we should pick up determinants of health, and I'm looking into social determinants of health in the breast cancer care in Malaysia. Touching a bit on current situation in Malaysia, what we have done thus far in terms of ethical collaboration and works in progress. And I believe today, the end of the day, we can have ideas, thoughts, sharings on how can we play our part in our individual role in wherever we are in collaborating and providing the necessary footstep in addressing this issue. So next, this is my disclosure. Next. So that's quite a standard thing that we have to do. So I am nothing compared to data that was shared by Dr. Isabel. GCO has been the forerunner of data, especially when we have lack of data in certain areas. A lot of projection forecasting that we use from GCO. But today I am basing this on local data, Malaysian National Cancer Registry, which is updated till 2016. We hope the next 5 years will be out soon. This is the base that we have now, so we use with what we have. Just to put the breast cancer burden and how the health system works here is that we know 34 out of 100,000 women affected by breast cancer, and that's the most concerning us is 52% is undiagnosed, and most of them come at a later stage. If you look into the 5-year relative survival rate for stage 4 is at 23%, much lower because of the late diagnosis. This is very top line data that's concerning, that's alarming, where this area of breast cancer can have high survival rate, as explained by Dr. Isabel, if they are what they call diagnosed early. There's a lot of chances here. So I just want to paint a picture on how the current situation looks in Malaysia. Next. And sorry for the long reference because that's really a detailed one. I tried to summarize this. We estimated 88% of excess death were avoidable, with 57% is late stages, I explained earlier. The delays usually result in large tumors, progression, poor prognosis. So these are common things happen when you come late. And in Malaysia, we lack the most developed nation in terms of survival outcome. Perhaps we can move to the next chart to showcase where we stand. So this is basically from the references earlier. I just putting it here so that we all can have a look on where it stands. And of course, the best is up to 2016. We have. So this is stage of diagnosis and 5-year relative survival. Not doing that well though. We can always do better. Next. So why we are looking into here is that the call out here, can we address the social determinant for a strengthened healthcare system? We understand there is issues on diagnosis, treatment, whichever, but can we address things that within the control beyond dollars and cents? Next. So here I just want to know, I think this is not alien to many of us. Here is a social determinant of health. This is from CDC. Social determinant of health is social and economic factors that impacts health outcome. Simple as that. Is the condition where we grow, we work, we age. It's a wholesome thing, right? So this is the bucket. I think it's quite a nice representation. WHO has a operational framework on this, quite thick. This is more easier representation for a social determinant of health. Let's move on. So we commissioned advocacy study, and this is available in public domain, where this social determinant of health impacting breast cancer in 3 key manner limited access to preventive screening like mammograms, delayed diagnosis due to lack of awareness and fear of seeking care, influence treatment option, adherence to treatment plans. I think this is something physicians would see on a day-to-day, but these are something we can act upon just beyond what I mentioned on our fiscal capability of spend and getting the right treatment. But these are things that get people diagnosed earlier so that we can do action upon. Next. So these are health system gaps addressed, and we did it together in collaboration with the IDES Institute and University of Malaya. Next, I think it's motion. You need to click a couple of times. One more. Okay, so these are barriers and burdens that we see. So based on the qualitative study and a roundtable discussion we had with key stakeholders, I think we had a lot, close to 80% of the key players within the breast cancer space, academia, NCCM, also patient groups, oncologists. Delayed presentation is taking 2 to 4 months, time to diagnose up to 9.3 months. These are hard facts, hard documented facts. And limited access, timely optimal intervention, advanced stage diagnosis increased from 43% to 48%. So 48% was the 2011 to 2016 MNCR data, but you look into the 5 years prior to that, it was 43%. So it's an increase in 5%. Fire relative survival was 67% compared to other nations. Down there, where the barriers would be the poor health literacy and awareness, accessibility to resources, and the most important thing that we think was documented in the paper was a disjointed effort. That's where we can be more synergistic in where we do things. Next. So, I think most of my talk today would be more on solutions and impact that has been carried out. Just to share some are work in progress. I hope that can spark some thoughts and idea in the capacity that we are in. Next. So this is the National Strategic Plan for Cancer Control Program. So before we start doing anything, we used to have this as the baseline to understand and read out what is drawn out in the next, I would say, next 5 years. It's coming to an end. I think the overall targets was set up was quite clear, especially in the downstaging of the presentation of patients, and we want to reduce the survival rate. We want to improve the survival rate and reduce the premature mortality. I don't want to get stuck into this because I think we had a long session with Dr. Isabel on this, but this is very specific to Malaysia. It's the national document. Next. So from Novartis' perspective, I think the commitment was we are supporting the NSPCCP, and how can we look into accessible and affordable prevention, control and management of cancer to patients through collaboration with various stakeholders and players. Next. So we came out with this. This is our in-house program, and we shared this with the Ministry of Health back then during KJ's time, just before 2020, I think. So we wanted to work on a couple of areas, 6 platforms actually. But of course, by many reasons, some took off, some didn't took off, and we had to do a decentralized model in our effort. But the idea of this program is to improve national outcome of breast cancer, as simple as what is underlined in the NSPCCP. And these are the 3 areas we wanted to detect early, diagnose early, and treat early. And also to add on to build the capacity to do that in areas we could collaborate and work upon. So I think I've spoken about this. I think this is a very good material for a reading. We commissioned this, I think, 2 years ago. Breast cancer care in Malaysia, gaps in early detection, diagnosis, and treatment at all stages. Of course, we've submitted this to the Ministry of Health for their reading and action upon. But this document, I would say, it's a very, very, very good document. It really spells out the gaps, the burdens that I've mentioned earlier. Very, very substantiated and having consensus from various parties. Next. So this was the base point for us when we look into how the patient pathway works on various intervals, both on detection, diagnostic, and treatment interval. Where is the gap? How can we work? What are the low-hanging fruits? What are something complex for us that we alone can't do? We need more players, more collaborators in it. Next. So one of it was the screening and diagnosis part. So what we did was, this is really a behavior science kind of thing. So we set out to do a qualitative study with the PERCA B40 team under Protect Health in a couple of places. I have data later on the correspondence and what we found out. But the idea is to understand the awareness, why there's reluctance, is there a solution, and of course the goal is improve literacy, screening and detection time, and following up with patient empowerment, why they need to be aware of all this. Can we have the next one? So I think, yeah. So this is a snapshot of what we did. I mean, the respondents was, I think not much, but I thought Penang and JB would be very much representative in this, I mean, as a location. We have a lot of this kind of data can be done in KL or Klang Valley. But on a very high level summary, what I would say is that the health seeking behavior is very poor. There are a lot of reason for that. Sometimes incentivization works. Having a hamper down there, you can push people from PPR to come and do screening. But we're already spending a lot in screening. We want to spend more on mammograms. Here we work with the local GPs. I hope you all understand how the PERCA B40 system works. But what we think is that it's a lot of behavioral changes, especially within the B40 community. And we don't do the slicing yet. We know there's a lot of undiagnosed late stage at 50% 58% if I'm not mistaken, for the 52%. But if we were to slice based on socio-economic status, we might have more idea on that. We didn't do that slicing. Maybe it's a behavior thing. When you act upon a behavioral change, suddenly you see a difference in the diagnosis, or patient public willing to come upon for screening, and their awareness on getting to screen and diagnose is much higher. This is something we found, and we also shared this with the relevant authority. I think there's something we can do. Of course, changing behavior need a concerted effort from all quarters. But this, I find, was very interesting data on behavior, especially with the questions that we put. I think that's something we can think upon, something we can do in a mass survey to see from within a time frame of 3 years whether there's a change in patient behavior in certain areas that we see high rate of late diagnosis. It's something we are thinking about. Maybe anybody would be interested to do it for us as well. So let's see how it goes. So these are two things that we are embarking on now, which is one on the population health outcome projection of treatment optimization in specific population. I can't go much detail on this. This is very much of a health economics kind of modeling that we are trying to do, where we try to look into a specific target population with highest or the best outcome given the accessibility to treatment and screening, where we can target some of our resources to have the best outcome in patient. So it's more for modeling, how much need to be spent over X years, where and how does it change the landscape of survival. So it's simply a mathematical modeling that we are working with the ministry. I hope we see some light at the end of the tunnel, so that I can, if I'm allowed to share sometime later, I will be able to share on this. The next is something we are working with, I think it's that before, with NCCM. We call it Social Health Empowerment Project. We are looking into building a capacity and capability on patient navigation program. More of something like how you open up ways or something, where within certain areas or geographical area, what is the nearest available screening, detection or treatment, and other auxiliary support available. We get a lot of support from many quarters, academia and stuff like that, but looks like NCCM would be the champion on this. I think they're the right party. Something we really want to do this, because this is something will change the landscape for patients. Everybody have a smartphone, at least this today, so you just open up, you know where to go and get it done. I hope we can conclude this by 6 months, something live and going, and something we can be proud of. If this is a success, then we can expand this to other cancer areas. Of course, as I mentioned earlier, breast cancer is a subject that we took, but if it can be expandable, then why not? These are two exciting work in progress that I would like to just give a heads up to the audience here. And as a conclusion, I think the brighter future in breast cancer is, I like to put this beyond medicine. I think the social determinants are very important. The socioeconomic status, education, cultural belief. If we can address these gaps, these are really low-hanging gaps that we can address. A lot of behavior. This is another way we can able to strengthen our healthcare system. We are able to be very hyper-focused in things that we want to work on to have impactful changes in the numbers that we see earlier. So I do believe in this, and I think the result is coming. It's a matter of time. So that's my message to all of you out here. And one key component on making this successful, and this is my last slide, is collaboration. So I think one of my colleagues has another session on the next door, is ethical collaboration. It's really about how we can collaborate for success. And MOH was a key player. I would like to say kudos to them. We have to accelerate digital transformation of healthcare services. Having that in hand really changes the whole landscape of patient journey, continuum of care, from detection, diagnosis and treatment, and of course post-treatment as well. Data generation is very, very key. We struggle in that at times. Increase patient access to innovative treatment. This is another topic, but I think that's key. And also evidence-based policy making, which would be more impactful in policy that we roll out. That's all from me. Thank you.
Thank you, Mr. Jega. So now, we are running short of time, so I can only allow 2 questions. So, any question from the floor?
I'm from IBM. I have a small question, if I may, to Professor Victor. This is more about, because you specifically discussed about the occupational related determinants.
Yes.
So what is your insight about excessive stress, work related?
There are basically talking about cancer, which is I did not present, which is on shift work. So shift work, there is a relationship between shift work and cancer, but that is another thing that I did not present. Right? Yeah. It's more. Stress itself is very difficult for you to actually measure excessive stress in the workplace.
Right.
And of course, we are coming out with, the Department of Occupational Safety and Health is coming out with a guideline on mental health at the workplace, which is basically going to be launched soon, because part of the new Occupational Safety Health Act is to look at the mental health issue.
Okay, so I think, would you agree with me that if, in your own opinion, that this stress is actually can be one of the determinants, an important determinants of the...
I don't know. I cannot agree with you. I'm not going to agree with you because I don't know. The main thing is, the main important part is that there are studies that have been done on other things that look at it from that perspective, like shift work. Alright.
Thank you so much.
No worries. Yeah.
Any more questions? Okay, personally, I would like to ask Mr. Jacob. So, we did try to conduct a community surveys for lung screening, lung cancer awareness in B40 community, but as you say, they don't really willing to participate. So, can I learn some tricks from you? Like, how are you going to get them to participate?
To do alone is always tough. If you go solo, it's always tough. It should have a lot of support from the local, either town council or local patient group. We know they're a huge patient group, based in Malaysia, but you might be surprised there are a lot of local patient group. I think NCCM would be the best to advise on this. They have a lot of local, within the residential or within the PPR to sort of rah-rah and push them. So for us, when we did the survey, we actually packed with the Perka B40 initiative, and even they had to either work with the Penang state government, in Johor local town councillor, so to have that drive of people coming. Incentivization, it depends. It depends on who's running it and stuff. But what I believe is that the moment you have incentivization to come and screening, it's good, but it doesn't really change the behavior. It's a very short-term measure, in my opinion. It's good to get like a dipstick test, like a litmus test. Stop. I want to know what's happening. But if you want to have a behavioral change, no, I think it's very much on changing the way they think and stuff like that. And we need people who are close to them, people within the circle.
Basically, I'd like to add to that. The problem is not just Perka B40. The problem also is in our SOCSO screening program where the rate is very low. So I think what we are doing in through our public health department and also UMMC is that we are going to the community to actually do the screening. We are bringing the screening there for them, because there are a lot of social things that you don't understand, like what was mentioned this morning. They don't have time to actually come to do the screening. Correct. They have so many other things to do, and you expect them to come and screen for you. And that's why we do the screening and bring the whole team there to actually do it for them. Right. I think that is how we can move forward in some of the areas, especially the Perka B40 area, where you can actually go for your team to actually go there.
Most of them are daily wage earners.
So
that's why they told us they need to work.
So if you do it in the weekend, and then they would basically be there, have some party and things like that.
Thank you so much to all the speakers again. I think we have token of appreciation to our speakers.
So if I could invite both of the speakers to come to the floor and can present the awards to you guys as a token of appreciation.
Thank you.